Hey there, and welcome back to another deep dive.
Good to be here.
Today, we're really zeroing in on a very common pediatric condition, super important for your understanding, especially if you're prepping for exams like the MSRA.
That's right. We're talking about undescended testes, or Cryptorchidism, as it's also known.
Exactly. It crops up a lot, and getting a really clear, sort of concise grip on it now will definitely save you some headaches down the line.
And we've basically boiled down some key revision notes to just the essentials, really focusing on efficient learning.
So our mission for this deep dive
Is to pull out all that high-yield info about undescended testes. We'll organize it logically, maybe throw in a memory hook or two to help it stick, ready to jump in.
Absolutely. Let's start right at the beginning. Definition. What exactly is an undescended testes?
Okay, so, simply put, it's when one, or sometimes both testicles, haven't completed their journey down into the scrotum before a baby boy is born.
Right. So it's congenital, present at birth.
Exactly. And it's something that always needs medical attention. It's actually, more common than many people realize, so having a solid understanding is vital.
Okay, so it's not just a simple case of it's not there. Our notes mention there are different sort of types or classifications. Can you walk us through those?
Sure. Let's start with retractile testes.
Yeah.
These are pretty common, especially in younger boys, before puberty hits.
Okay.
You might feel the testicle up in the groin area,
Mhm.
and you can often gently guide it down into the scrotum.
Okay.
But the thing is, it tends to pop back up, especially if the boy is relaxed or maybe cold.
So it doesn't stay down reliably?
Precisely.
Yeah.
And these need monitoring because there's always a small chance they can become truly undescended later on.
Right. So if you can manipulate it down fairly easily, but it won't stay put, think retractile.
Yeah.
Got it. What else?
Then there's something called ascending testis syndrome. This one's less common and often seems to affect the left side more.
Ascending, so it was down before.
Yes, exactly. It's usually diagnosed a bit later, maybe around age 8 to 10. A testes that was previously noted as being down the scrotum moves back up and then stays there.
Interesting. And the third main type?
That would be maldescended testes. These are usually unilateral, so just affecting one side. And you might notice the scrotum on that side looks a bit, underdeveloped.
Okay. And what causes those?
It could be down to physical issues, like something blocking the normal path of descent or sometimes hormonal factors. But interestingly, a good number of these, the majority actually, will descend all by themselves within the first 3 months of life.
3 months. That feels like a really key window then.
It really is. And, within that maldescended group, we can get even more specific. Sometimes the descent just stops partway down the normal route. We call that arrested descent.
Arrested. Okay.
Other times, the testes goes off-piste, essentially. It deviates from the usual path and ends up somewhere unusual, like the thigh or perineum. That's ectopic descent.
Okay. Arrested or ectopic. Makes sense. The notes also bring up the EAU classification. How does that fit in? Is it useful in practice?
Ah, yes, the European Association of Urology classification. It's really helpful because it gives us a very clear framework for describing and managing the condition. It basically divides them into palpable or non-palpable.
Palpable meaning you can feel it on exam.
Exactly. So palpable testes could be sitting in the inguinal canal, that's the groin, or they could be in one of those ectopic locations, or they could be retractile, like we just discussed.
And non-palpable.
Non-palpable means you can't feel it. It might still be in the inguinal region, but just too high up, or ectopic, but hidden away. Or it could be right up inside the abdomen. Or, in some cases, it might actually be absent altogether.
You're absent like it never formed.
Precisely. That's called a genesis.
Mm.
Or there's something called a vanishing testis, where it seems it might have formed initially, but then sort of regressed while the baby was developing.
Wow. So that palpable versus non-palpable distinction seems pretty fundamental for the initial assessment then.
Absolutely. It really guides your next steps in terms of investigation and management.
Okay, let's shift gears a bit. What actually causes this? Why does a testite sometimes not make it all the way down? What's the etiology?
Well, it's generally thought to be multifactorial. There isn't usually one single smoking gun.
So a mix of things.
Exactly. We know genetics likely play a role, and hormonal factors are definitely key. Things like insufficient production of certain hormones by the fetus or the placenta during development that's thought to disrupt the normal descent process.
Hormones are crucial for that journey then.
Very much so. While we haven't pinpointed specific genes in most sort of isolated cases, they're probably involved. Risk factors also add to the picture, but often, it just happens as an isolated thing without a clear single cause we can point to.
Right. And speaking of risk factors, those are always good to have filed away, especially for exams. What are the main ones we should keep in mind here?
Okay, the key risk factors to remember are definitely premature birth, that's a big one, as descent often finishes late in pregnancy.
Makes sense.
Also, low birth weight. A family history of undescended testes is important too, suggests the genetic link. Maternal smoking during pregnancy is another one.
Right.
And then there are certain associated genetic syndromes like Prader-Willi or Kallmann syndrome where it's more common.
Okay, let's try a quick memory aid for those. How about premature babies with low birth weight whose families sometimes smoke might have swine-indromes?
Haha, yeah, that works. Pre-Low-Fam-Smoke-Syndrome, whatever helps lock it in.
Definitely. Okay, so we know the risk factors. Let's talk pathophysiology. What's actually going wrong with the normal process?
Well, as you know, the testes start their life way up in the abdomen, near the kidneys.
Right.
And then they have this quite complex journey downwards through the inguinal canal and finally settling in the scrotum, usually just before birth.
So in undescended testes, that journey gets stalled somewhere.
Exactly. It's either halted completely or significantly delayed. We think hormonal imbalances play a big part in coordinating this whole process. And sometimes abnormalities in the actual physical structures involved, like the gubernaculum, that's a sort of ligament that guides the testes down, can also be a factor.
So it could be the signals or the pathway itself?
Correct. And that's why, as we discussed with the classifications, the testes can end up stuck anywhere along that route, or even retracting back up.
Okay, so when you're examining a baby boy and you suspect an undescended testes, what else might be going on? What are the main things you need to differentiate it from? The differential diagnosis.
That's a really critical point. The main differential is, of course, a retractile testes. Remember, that's the one you can often manipulate down into the scrotum, even if it pops back up.
Right, the manipulator.
Yeah.
Memory tip, maybe. If you can push it down, think retractile.
Good one. Then you also need to think about an acquired undescended testes, sometimes called an ascending testes. That's where it was down before, maybe documented on previous checks, but now it's consistently up.
Okay, so history is important there.
Very. And finally, you have to consider the possibility that the testis isn't there at all. That's testicular agenesis.
Yeah.
Or maybe it's there but very small and shrunken, which is testicular atrophy.
Yeah.
That might make it hard to feel.
Right, so a really thorough physical exam plus knowing the history is absolutely key to sorting these out.
Definitely.
Let's talk numbers then. How common actually is this? What's the epidemiology look like in the UK for kids?
It's actually the most common birth defect involving the male genitals. In full-term baby boys born in the UK, the prevalence right at birth is somewhere between, say, 2 and 6%.
2 to 6%. That's not insignificant.
No, it's not. But check this out. In premature infants, the rate shoots way up. We're talking 30 to 45%.
Wow, nearly half in some cases.
It's a huge difference. And it's also much more common for just one testis to be affected that's unilateral. That happens about 4 times more often than both tests being undescended, which is bilateral.
Okay, striking numbers, especially for the preemies. So what usually flags this up? What brings a child to attention? What are the key clinical features?
Well, the most obvious finding, the key one really, on physical examination, is simply the absence of one or both tests from the scrotal sac.
An empty scrotum, basically.
Essentially, yes. If the testes palpable, you might feel it somewhere along that path, maybe low abdomen, often in the inguinal canal and the groin, or sometimes just outside the scrotum in an ectopic spot.
And the retractile ones?
With retractile testes, as we said, you might see it pop down into the scrotum temporarily, but then it shoots back up. Less often, maybe some associated symptoms like a bit of groin swelling or perhaps some discomfort, but usually it's just the absence on exam.
Right. So when it comes to actually working out what's going on, what's the standard approach? What investigations are typically done?
The number one diagnostic tool is without a doubt a careful, thorough physical examination.
Hands-on is key.
Absolutely. You want to feel for the testes with a child in different positions, often lying flat, supine, and maybe sitting cross-legged, which can sometimes help relax the muscles. Visual inspection is important too.
Yeah.
Does the scrotum look symmetrical? Is one side underdeveloped?
What about that reflex that pulls them up?
Ah, the cremasteric reflex. Yes, you need to try and minimize that. Gently stroking the inner thigh can sometimes help inhibit it. And techniques like gently sort of milking downwards from the groin could occasionally bring a high-ish palpable testes down where you can feel it better.
Milking the groin. Okay.
Don't forget to check those other potential ectopic spots around the thigh, femoral region, near the base of the penis, the perineum. You need to be thorough.
So Really putting the time into that hands-on exam is the most crucial first step. What about imaging then? Does ultrasound or MRI have a role?
Generally, imaging like ultrasound or MRI isn't routinely needed if you can actually feel the undescended testes. The exam is usually enough. However, if the testes is non-palpable, you just can't find it, then imaging can be helpful. Ultrasound, or sometimes MRI, might be used to try and locate it, maybe see if it's up in the abdomen or high in the inguinal canal, assess its size, viability, that sort of thing.
So more for the non-palpable cases.
Primarily. And for confirming the presence and location of a non-palpable testes inside the abdomen, diagnostic laparoscopy keyhole surgery is often the gold standard.
Right, going in with the camera.
Exactly. Now, abdominal and pelvic ultrasound is sometimes indicated if there's a suspicion of an underlying intersex condition or differences in sexual development. And occasionally, hormonal tests might be used, particularly if both tests are non-palpable, to check the child's hormonal function.
And you mentioned the EAU guidelines before they really stress the urgency for those bilateral non-palpable cases, don't they?
They absolutely do. If you have a case of bilateral non-palpable tests, especially if there are any other concerns about the baby's sexual differentiation, that warrants a very prompt referral. We're talking ideally within 24 hours to a senior pediatrician for urgent endocrine and genetic workup.
Okay, high alert for bilateral non-palpable. Got it. So, moving on to management. We found an undescended testes. What's the general approach in the UK?
Well, the first thing to remember is that many cases, especially those picked up in newborns, will actually resolve on their own. Spontaneous descent is quite common in the first few months.
So watch and wait initially.
Often, yes, up to a certain point, usually around 6 months of life. If the testes hasn't come down by then, surgical intervention is generally the next step. For retractile tests, though, it's more about close follow-up, as they can sometimes become truly undescended later.
And for a typical unilateral case that doesn't descend, what's the timing for referral and surgery?
For a unilateral undescended testes that's still undescended by around 3 months, referral to a specialist, usually a pediatric urologist or surgeon, is recommended. Ideally, they should be seen before 6 months of age.
And the surgery itself.
The operation to bring the testes down and fix it in the scrotum that's called orchopexy is typically done around 1 year of age. The goal is definitely to get it done before the child turns 18 months old.
Okay, so referral around 3 months, seen by 6 months, surgery around 12, 18 months for unilateral. And bilateral, as we said, is more urgent.
That's right. Bilateral cases need that immediate senior pediatric review for the endocrine genetics side of things. And if spontaneous descent doesn't happen, surgery is generally recommended earlier, often by 6 months of age, really to try and maximize the chances for future fertility.
What about medical options? The notes mention hormones like HCG or GnRH being used sometimes. Is that still common practice?
Hormonal treatments using HCG or GnRH were definitely used more in the past to try and encourage the testes to descend.
Did they work?
Well, the current evidence on their long-term effectiveness, especially regarding fertility outcomes later on, is pretty limited, frankly. Plus, HCG can have side effects, temporary enlargement of the penis, bigger tests, and there are even some studies raising concerns about potential negative impacts on future fertility down the road.
Okay. So not really first line anymore.
Generally not. Its use is much more selective now. Surgery orchidopexy is really the mainstay of treatment for testes that don't descend on their own.
Okay, so let's talk orchidopexy.
Yeah.
You said ideally after 6 months, but before 18 months. How is it actually done? Are there different techniques?
Yes. So if the testes is palpable, meaning you can feel it in the groin, the most common approach is through a small incision directly in the groin crease.
Open surgery.
Right. The surgeon finds the testes in the spermatic cord, carefully frees them up to get enough length, and then brings the testes down into a small pouch created in the scrotum, fixing it there. This inguinal approach has a really high success rate, often up to about 92%.
And what if it's non-palpable? You can't feel it beforehand.
For non-palpable tests, laparoscopy keyhole surgery is now usually the preferred first step.
Going in with the camera first.
Exactly. It allows the surgeon to look inside the abdomen, find the testis if it's there, check if it looks viable, and then decide the best way to proceed. Sometimes they can bring it down in that same procedure, a one-stage operation. Other times, especially if the blood vessels in the spermatic cord are very short, they might need to do it in 2 stages.
Okay, so palpable usually means an open approach via the groin. Non-palpable usually means laparoscopy first. Makes sense. What's the general outlook then? If a child has this corrected, what's the long-term prognosis like?
Generally, the prognosis is very good, provided it's managed in a timely and appropriate way.
Hmm,
Orchidopexy is considered a safe and effective operation. Early diagnosis and treatment really do minimize the risk of complications later on.
that's reassuring.
It is. But it's still important for families and the individual later in life to know that even after successful surgery, there might still be slightly increased risks for certain things compared to someone who never had an undescended testis. So regular follow-up is still a good idea.
Okay. And what are those specific potential long-term complications we need to be aware of?
The main ones are, firstly, infertility or subfertility. This is a bigger concern in bilateral cases, where both tests were undescended. Some studies suggest fertility issues in up to maybe 56% of those men.
Wow, over half?
It can be significant. For unilateral cases, the overall sperm count is usually normal, but there might be some subtle effects on sperm quality. Secondly, there's an increased risk of testicular torsion, where the testis twists on its cord. That's thought to be due to slightly abnormal fixation within the scrotum.
Right, that's a surgical emergency.
It is. Thirdly, and this is a big one people worry about, is testicular cancer. Men with a history of cryptorchidism have roughly a 3 to 5 times higher risk of developing testicular cancer compared to the general population.
3 to 5 times higher? That sounds alarming.
It's a significant increase, yes.
Hmm.
But it's also important to keep perspective. Only about 5–10% of all testicular cancers actually occur in men who had an undescended testes. But the increased risk is definitely there.
Okay. Anything else?
Yes, potential psychological impacts may be related to body image, especially during adolescence. Also, the undescended testes, even after being brought down, might be slightly more prone to trauma because of its position or fixation. Cosmetically, though, the surgery usually results in a normal-looking scrotum. And if for some reason a testis needs to be removed later in life, a testicular prosthesis can be an option for cosmetic reasons.
Those are definitely important long-term considerations. Really highlights why getting it sorted early is so important. So what can be done to prevent these complications or minimize the risks?
Well, the most crucial preventative steps happen early on. That's careful screening of all newborn boys, checking the scrotum within the first 72 hours of birth, and then again at the 6–8 week checkup.
Standard checks.
Exactly. If an undescended testis is found at birth, it needs to be rechecked around 4 to 5 months to see if it has come down on its own. If not, that's when the referral pathway kicks in.
And the orchidopexy itself helps prevent complications.
Yes, the surgery itself is seen as a key preventative measure. Bringing the testes down into the scrotum makes self-examination much easier later in life. That's vital for early detection of testicular cancer should it occur.
Right, easier to feel for lumps.
Precisely. And there's also some evidence suggesting that performing orchidopexy before puberty might actually lower the overall risk of developing testicular cancer later, although the exact extent of that benefit is still debated and researched.
Okay, so the clear message is screen early, check again if needed, refer promptly if it hasn't descended, and aim for timely orchidopexy. That seems to be the key pathway for the best outcomes and reducing those long-term risks.
That really sums it up perfectly.
This has been an incredibly useful, really clear run-through of undescended testes. We've covered all the core areas definition, the different types, causes, risks, how it presents, investigations, management, and those important long-term points. Definitely feels like high-yield stuff for anyone prepping for the MSRA.
Absolutely. Getting your head around the classification, those key risk factors, especially prematurity, the management timelines, particularly those referral points and surgical windows, and being aware of the potential complications like infertility and cancer risk, that's all crucial.
And hopefully, our slightly silly mnemonic for the risk factors, remember, Premier's lower fame smoke and cause Sass-Weinandromes might just help lodge those associations in your brain.
Fingers crossed. Every little helps during revision.
It really does. Now, for listeners wanting to dive even deeper, find more study materials, practice questions to really test your knowledge on this and other MSRA topics, make sure you check out PathNosRA.com.
And for a wealth of other fantastic free resources, guides, and tips to help your preparation, definitely head over to freemsra.com as well.
Great resources. Well, thank you so much for joining us for this deep dive today. We really hope you found it helpful and clear.
Hope it helps with the revision.